AKT Decoded, breaking down the questions regarding AKT and what it means for you as a GP trainee preparing for your exams. Today's session is following up on our first introduction to AKT, which is the AKT in a few minutes, which was a session done by Dr. Bakari. It's a very great session explaining the current AKT practice. So if you're watching this video for the first time and you haven't watched that AKT in a few minutes, my advice is to pause this video, watch that first introduction video, and then come back to this so that your learning today makes sense. It adds up to you for has more impact. So what are we going to talk about today? We're going to talk about AKT questions format and the blueprint. We're going to talk about time management strategies, preparing for the exam, so that you are optimizing your opportunities to have a good pass, clear pass in the exams. We're also going to talk about how to study, knowing where to go look for high-yield questions, and also ensuring that your non-clinical topics are well covered. And of course, the main topic for today, the main reason we are here is to discuss the question types in the exams and the tactics you need to improve accuracy. So hi, everyone. If you don't know me by now, my name is Omosfe Christina. I'm a GP, I'm a tutor, I'm the CEO of Elite Exams, and most of all, I am an IMG like you, and I'm here to share the best practice for the AKT, some of the things that I've learned to make sure that you are well prepared and not making the same mistakes that I made preparing for the AKT. So before we start today's session, I want to give credit to Dr. Ian Lauter. In my AKT session, as a trainee, my VTS recommended his lectures, and thankfully he was in town, and I got registered on a study leave by the VTS to attend his lecture. And the original slides are on the internet if you search for them. Due to copyright, I cannot share his slides here because I do not have his permission to share his slides directly. But the original slides are still on the internet in his VTS if you would like to go read that and learn directly from him. But I remember these things he taught me back then, and they also formed part of the knowledge that I used in preparing for the AKT. So our TGP defines the AKT as an essential part of our GP training. With the AKT, they're not aiming for us to recall or answer questions like SHO. Chest pain can lead to death, true or false. That's not the kind of questions they're asking for. Those true and false questions, those direct questions like in medical school or PLAB exams, that's not what this exam is about. What they are doing is testing your applied knowledge of clinical practice. That's why it's AKT, applied knowledge test of your clinical practice. And the key thing here is knowing what the questions are asking for and demonstrating how you would act in real life practice. So if I'm saying a gentleman came in, 64-year gentleman came in with chest pain, shortness of breath, and um, cold sweating. He mentions that this happened 2 times before and he didn't see the doctor. And at the moment, he's breathless, his blood pressure is 90/40. He's what else? He's cold and clammy. What would be the most appropriate action at the moment? So my question was, gentleman comes in with left-sided chest pain, shortness of breath, sweaty and clammy. That alone tells you this man is most likely having a heart attack. Yes, with him being hemodynamically unstable and all of that, he's most likely in cardiogenic shock. But my final question says, what's your most appropriate action? Now, the first thing you need to do is think, oh, what's the diagnosis here? Myocardial infarction. What's going on here? Cardiogenic shock. What is then? You now look at your question. What's your most appropriate action to take?
Yes, call an ambulance.
You call an ambulance. And that's what the AKT is testing for. So it's not going to tell you, is this man in heart attack? Or yes, there are some questions that will ask you, what is the diagnosis? But before it leads to that, they're asking you to interpret the clinical symptoms and then pick the diagnosis. Or they're asking you to interpret the clinical symptoms they've described, think of your diagnosis, and then think of the action, like call an ambulance, or think of your treatment. Which medication will you give? So if I come in and says a 54-year-old lady who is obese with right knee pain, complains of difficulty walking up the stairs. She has a chronic kidney disease of stage 3, and she's asking you for analgesia pain control. What would be your most appropriate medication to prescribe? So first of all, you need to think, oh, with this description here, what's this lady's diagnosis? And I've just described osteoporosis, knee pain, difficulty going up the stairs, struggling to walk, asking for pain medication. I haven't given you any other sign that this is septic arthritis. It can't be congenital at 54. So right, by interpreting the clinical symptoms described, you first need to think of your diagnosis. And then it's the question. The questioner asking you, what is the drug to prescribe? But this lady has CKD. Who would prescribe NSAIDs for this lady? And the options will be there. NSAIDs will be there. Coxib will be there. Codeine will be there, pain gel will be there, and it will ask you what is the most appropriate. Now you have to think of evidence-based medicine. Evidence-based medicine is either codeine or pain gel. So what does your night CKS say to be the first line option? That's what you then pick as your answer. And that's what the AKT is about. And it took me a long time to understand what they were looking for in the AKT until I attended Ian Lauter's lectures. So if you hear that Ian Lauter is coming to your area and there is a lecture, it's free, please attend. If it's already in your area, if you live in the same area as him, ask your VTS if he's still having these lectures. My recommendation is to attend because he really breaks down the format of the AKT, which I am going to cover. But there was just something about his lectures that really helped me years ago. So I'm hoping that you are starting to see what the exam is looking for. They're not asking you to do true or false. They're not asking you to answer questions like SHU or medical students. You are here to show that you are able to practice as a GP by understanding or decoding complex clinical symptoms and then taking the right action. And to take the right action, if you don't have the right diagnosis, you will pick the wrong action and fail that question. So moving on, coming to our questions. You have 160 questions, you have 2 hours plus. If you break down the questions, it means that you are actually meant to answer a question in 57 seconds. That means that you have to read this them, read everything, and some of them can be a long, difficult question. Some of them are very short and simple, some of them very long and difficult. And you're meant to answer each question an average of 57 seconds. Can you do this without practicing? Can you do this without months and months of preparation? Because they want to see that you are able to think quickly on your feet. Because in real life, your patient comes in and tells you A, B, and C. You have identified the pattern and you are starting to ask questions to confirm whether it's actually that diagnosis or to check for other diagnoses. So in that case, we are meant to be able to work fast, be able to study hard to work fast to prepare, and be able to ace this exam because time management and resilience is very important. There are loads of study materials out there. So this is a list which I will share in the group so that you can have them. You need to know the GP curriculum and please stay updated with the latest GP curriculum. We are meant to study the GP curriculum, the latest versions, actually look at RCGP's recommendation on AKT, the list of topics, clinical topics. The BNF, the NICE guidelines, we need to study them because you need to learn prescribing. They will bring drugs, drug monitoring, and please, these things we've covered them in our first lecture. So here are a list of resources which we know online, including vaccines, the updates, the newsletter. One thing I realized is not here is MHRA. Okay, sorry, that would be under with BNF. MHRA is an agency that monitors medications, new medications to the market, side effects of medications, and they send an alert to all doctors and they put it in the BNF to warn us that this thing is a common mistake with this medication or this drug has been found, new evidence to cause this problem. Right. So with the vaccine update, there is also an MHRA organization. It's an agency that sends alerts regarding medications. Now, this agency would study the market, look at evidence from research, and then they send alert warning to all doctors. It's in your BNF. So you might see MHRA alert. Don't ignore those kind of alerts when you are looking at drugs. The alert will tell us that, oh, more and more doctors are making a mistake in this medication. For example, methotrexate. There was an alert about 2 years ago, and it was a big problem in the UK that MHRA was warning everybody about methotrexate errors, medication errors that was really bad. The last one that came last month in my inbox, I subscribe to them, so they send me, I get the alert straight to my inbox, was opioids. They were warning that opioid addiction is becoming too much in the UK, that we doctors need to be stricter in prescribing opioids because we are now having opioid crisis in the UK, the same way it is in America now. So they sent alert. So that MHR alert can actually come in an exam. Once there is an update to a drug, to a clinical condition in BNF, 90 years or sign, they will give us time 3 to 6 months before that update starts showing in exam. So if they update a clinical problem or they send an alert today, it's not going to come automatically in your exam next week. They would allow time for us to learn, to catch up, and then you start seeing changes to clinical practice or exams would expect you to have learned that update by now. Now, for some people, reading, they prefer it. In GP training, you will realize that you don't have time to sit for 2 hours to study. It's not possible. So for me, video and audio was something that I did in GP training. If I'm driving to work, I had 40 minutes driving. I would put audio. YouTube will be playing in my car. That's what I listen to. Some platforms have audio recordings of AKT lecture. You just subscribe, just like Elite Exam, and you just see the person sitting down there teaching you AKT, and you are just watching. Those were the kind of things I subscribed to, and I paid for them, and I was listening to them. So please widen your resource of learning. Get attend AKT lectures. Some of them might be free, some of them might be paid. Get the flashcards, which helps you understand pattern recognition. Subscribe to question banks. The GP self-test question bank is free, but there are some paid question banks for AKT that you can use. And I've talked about high yield questions because they are very common in GP practice. RCGP really wants us to know how to manage those cases in real life. So what does the question bank look like, which is what I'm going to show you shortly. This is what the GP self-test looks like in your RCGP account. It's free for you as a GP trainee, or if you are registered as a member with RCGP. Even though you are a GP and you are still registered as a member, you can access it just like what I've done. And this is what your questions look like. In the exam, you will have it here as 200 questions. I've only just picked 16. You're able to go back and forth. At the beginning of your questions, you would see a title. For example, now this is the blue badge scheme, which would fall under practice management. If a patient comes and says, "Doctor, I've been struggling, I cannot walk, I cannot A, B, and C, X, Y, and Z." Holistic management means that you're not just treating the osteoarthritis, you're not just giving painkillers, you're also telling them, what about getting a blue badge disability registration, getting occupational therapy at home, all those things. So that's the blue badge scheme right there. And of course, the question is now asking. So, the main stem of your question, we'll talk about breaking down questions and then your answer topic. Your exam, almost like this. So if you're familiarizing yourself with the GP self-test, you are already mentally preparing yourself in the exam. And please don't just lie down on the bed and be scrolling passively. Sit down when you start. Sit down, don't put any timer, and just do the questions. Towards 6 months, 2 to 3 months before your exam, then you now need to start timing yourself to start picking up the speed of answering these questions. So this is just an example of what your GP self-test looks like. This is the real one, I believe. Yeah. Just showing you a demo of it. So it's in your RCGP account, and you can oh, so slow. Yeah, there we go. So you just keep moving. International exchange. So I've picked it up. That's only giving me statistics, lifelong learning. And now we're talking about international exchange opportunities, same way. And then you just keep clicking, answer your questions, click, and keep moving on. So please go and look in your GP self-test if you've never done, because you are going to start preparing for your exams, everybody. So you need to familiarize yourself. So we're going to go into the second part of our lectures, talking about the exam questions. Practicing each format matters. Pattern recognition is very important. So my experience with the AKT is that I studied and studied and studied for so long, and I attended in Laute's lecture, and I was the shocked night owl. That's why I picked the owl. Like after attending the lectures, I was like, really, this is something that I needed to know at the very end. I felt cheated that I didn't have the right information. So yes, this is how when I was looking for a picture to say, let me capture how I felt back then. This is me. I was the night owl, burning a lot of candles, trying to prepare for the exam, but I did not have the right information. So that was me shocked, and that was me red-eyed. Yes, yellow-eyed, but I was red-eyed, if you know what I mean. So different types of questions. There is a single best answer. You pick one answer. There is multiple best answer where you are picking more than two. It can be two or three. Can be extended matching. So you have one list of options and then different answers. You can pick different ones. And then table, algorithm, drag and drop, pictures, data interpretation for statistics, free text where you are typing in, and then ranking order. Okay. So let's go now. Single best answer. In this one answer is correct. You're only meant to pick one answer. The pitfall is many people study and say, oh, this is what I do in my area. These questions are testing national expectations, not what is done in your area. So know the difference. That's why I put it in red. Know the difference. So they are meant to answer based on evidence-based medicine, based on NICE guidelines, based on international recommendations, on the resources, the study materials I've listed, not what is done locally or what your ES says they prefer to be the answer. This is because the AKT is the same thing. We are all writing it across the four nations of the United Kingdom. So everybody's writing the same thing at the same time. So your questions need to be standardized based on national, not your local guidelines. In this question, they're asking you to pick what is the most possible, the most likely, but there will be other things there to distract you. Why is it important in real life? Because the patient will come, those of you who have gone to GP practice, patient will come and they want to talk about their knee pain, but they will tell you about 20 years ago how my back was, but you've come for your knee pain. There are other things that will distract you in that consultation. So you need to be able to filter out the information and pick your best, most likely your best possible answer. With this kind of question format, the question is most likely clinical situations in this kind of question format. So pattern recognition matters. I've taken the time to talk a bit about pattern recognitions at the beginning. It's something you have to put at your mind throughout GP training. Without pattern recognition, you can't function as a doctor. That's the truth. But for some reason, I didn't learn this back in my home country. I only understood it clearly when I came to the UK. And this is something they teach their British trained doctors, pattern recognition. If I come to them and say, oh, a 54-year-old with atrial fibrillation has come in with sudden abdominal pain, and abdomen is not distended. He opened his bowels today, and pain is not controlled by paracetamol. What's the first thing you will think of? Somebody will say, oh, sudden abdominal pain, is it indigestion? Your key thing there is that AF. AF can lead to blood clot. Blood clot can lead to mesenteric ischemia, and that's the cause of the sudden abdominal pain. This man opened his bowels today as a distractor because he did not have blood clot at the time. Constipation in abdominal pain is more of a, can come as a chronic thing, maybe 2-3 days or 2 weeks, cancer, then you start seeing constipation. So him opening his bowels today is a distractor. The key things there was AF, sudden abdominal pain, not controlled by paracetamol, mesenteric ischemia. That's my diagnosis right there. Now the question will not come as it may come as what's the likely diagnosis, or it may come as what's the most appropriate clinical action at this time. And that man needs an emergency admission to hospital by ambulance. Yes, by ambulance actually. Especially if it's hemodynamically unstable, but you need to be sending them out to hospital. So you need to know how to identify your distractors and how to recognize patterns in clinics and in your AKT. This is why it's applied clinical knowledge, not asking you, these are the common symptoms of mesenteric ischemia, abdominal pain, blood in the stools, and asking you to pick one. It does not come like that. So in a way to decode this question is to first read the question there, which says, what is the most likely? What is the least common? What would you do in this case? Read that question and then go back to the main stem, the whole description. That's your stem. That's how to work faster and smarter in clinical questions like this. Know your keywords. For example, in the case I gave right now, my keywords was AF, sudden abdominal pain. The rest of it was distractors. So without knowing this kind of pattern, you will struggle in cases like this. So look at a case now. A 64-year-old man presents with sudden onset of vomiting, constipation, abdominal pain, and distension. His wife mentions that over the last few months, he has lost his appetite, lost a lot of weight, and has 2 episodes of rectal bleeding. Now, in decoding a single best answer, the first thing I'll do is read what is the most likely diagnosis, select one option. That tells me, oh, if I'm going to read this, I'm thinking of the most likely diagnosis. So the first thing you do is, what is the most likely diagnosis? Select one option. Then I go back to the stem. 64-year-old man. While I'm reading, I'm identifying my keywords. My keywords are 64-year-old man, sudden onset, vomiting, constipation, abdominal pain, distension. He has lost weight. Red flag here. Colorectal cancer. The rest of it, which I have cancelled as an example, are just distractors. So you may have a lot. His wife mentions that this has happened in the past and it relieved suddenly on its own. He did A, B, and C, and now symptoms have remained constant for the last 2 days. Distractors. But in able to identify a 64-year-old man, age is important, because if this was a 24-year-old, there's a difference. So if I say 24-year-old, sudden abdominal pain, vomiting, constipation, abdominal distension, but in a 24, I might be picking inflammatory bowel disease that has perforated. You see how age changes everything? My most likely diagnosis would be IBD. But if I was saying, oh, a 24-year-old with long-standing or intermittent abdominal pain that is worse with eating certain food, with weight loss, he did not have rectal bleeding, I might be thinking of celiac. So in identifying your patterns, you are able to quickly, first thing that comes to your mind, they call it the first pass, don't overanalyze. 64-year-old, sudden vomiting, constipation, abdominal pain, distension with weight loss, red flag of weight loss, and rectal bleeding, colorectal cancer. What's your most likely? Yes, is it possible that this is uncontrolled IBD? They're not trying to trap you. They did not give you had a history of IBD and it was poor on compliance. No, they didn't give you all of that. So it's always straightforward, asking you your most plausible answer. So that's how to decode. That's how to identify keywords, red flags, eliminate distractors. But start by reading your STEM questions so that you know what you are doing. Am I picking one option or am I picking 2? Is it asking me for what I'm supposed to do with this diagnosis? Because this question can come in here and then says, what is your next course or initial management or final diagnostic option? So what question is here determines what you pick. But if you don't know the question here, you would read it, come back and go and start trying to figure it out again. So you need to learn to be smarter in the exam. That's the advice. Read your STEM questions first, then go back and read to understand what you're doing. So this question can change now, and I can list here as what is your initial course of action? What's your initial management? And I can put it here as routine referral, urgent 2 weeks, watch and wait. So in that kind of situation, I need to first think of the diagnosis and then come and pick action. So in my mind, I'll go like, oh, most likely colorectal, and then I will pick my 2-week referral. That's what AKT is about. Applying the clinical knowledge you read, not asking you for the clinical science, like which of these is not a sign of colorectal cancer. That's not what they are going to do. That's PLAB level questions. Here now they are testing our applied knowledge. The next one is multiple best answer. So here you're asked to pick more than one correct answer. So if you pick one correct and one wrong answer, you failed that question. And this kind of question, unlike the SBA, might come with 2 marks because each question is 1 mark, or it might come with 1.5 mark. You just never know. So this is why the exam is weighted, because some questions have more marks than the other. You just never know which one does. So you have to pick the 2 correct answer to get the full complete answer. So in this kind of case, the answers are more likely to apply to others. So if you're reading it again, read the STEM question, read the leading question to understand what you are meant to do. Pick 2 answers. Which 2 answers, or what are the 2 initial management to do? Which would be 2-week referral and do bloods, or 2-week referral and do an X-ray. Example for the colorectal CT scan. So now in that kind of case, they're asking you what are the 2 best options for initial management, because you now know your diagnosis. And the same principle applies. Know your keywords, know your red flags, eliminate distraction, but you need the right combination. Otherwise, you will not get that mark, full mark for that. So if you get one wrong, they won't give you half mark. You have to get full to get the full mark. So here is an example. Now we're going to do the same thing. I'm going to read the STEM. Which 2 of the following are the most appropriate next step in primary care? All these questions, I took them from GP self-test. So it's not cooked up. They're actually real questions from GP self-test. Which 2 of the following are the most appropriate next step in primary care? That means we're going to go into the question. So again, we know this is on Wilms tumor. A 3-year-old boy is brought to your surgery by his mother, distractor. 3-year-old boy, and who has noticed a firm swelling to the left side of the abdomen when changing his nappy. When changing his nappy is a distractor. It does not change anything, because whether they found it when he was playing or they found it when he was eating breakfast, it does not change anything. It's a distractor. The child is otherwise well, so hemodynamically stable, no fever, normal appetite, and no history of trauma. You see how it has removed your red flags and no trauma, red flag. So it's not a hematoma, no trauma. So it will not tell you that there is no hematoma. It said no history of trauma. You are interpreting no history of trauma to mean there is no hematoma. So on examination, you feel a non-tender, smooth, firm mass in the left upper quadrant that does not move with respiration. So does not move with respiration means it's not the spleen. On the left side, spleen moves with respiration, the kidney will not. Apply clinical knowledge. His urine dip is normal in the surgery. Urine dip normal has excluded adult polycystic kidney disease, because a tumor in a kidney tumor with blood in the urine is ADPKD. But now that the urine dip is normal, that has excluded your ADPKD. So you now remember that, they're asking you for your 2 most appropriate. So what would be the answer here? Arrange an urgent ultrasound within 48 hours. Consider urgent referral to pediatrics within 48 hours for suspected WIMS. Reassure the mother and repeat 2 weeks, repeat review in 2 weeks. Discuss the case with on-call pediatrician and arrange immediate referral, or start antibiotics. You can see, unlike that last question where it was short, this is long and you need to do it in 57 seconds. The correct answer here is B and D in this case. But this is just showing you that if you don't pick B and D, so somebody might say, I need to do an ultrasound. Why is not A? Because yes, the child needs an ultrasound, but why is it not A in this? They say your most appropriate next step. Most appropriate, patient needs urgent assessment, and you need to call the pediatrician. The pediatrician can do the scans when the patient is going. But if you are requesting an urgent scan is a scan within 2 weeks. So you are delaying the patient's care. That's why it's not A. This patient needs to be seen as soon as possible. So calling the pediatrician on the phone is appropriate. Arranging an urgent referral is appropriate. But yes, pediatrician can do every other thing rather than you waiting for an urgent ultrasound before you now refer the patient. So knowing if you're not picking the best 2, you will not get the marks in this case. Next question format, the third one is extended matching questions. In this one, they will give you a list. You will first see a list of options in these questions. And then they're asking you, before they bring the stems, so you will see maybe 7 to 10 options, sometimes maybe just 5. Then your questions come, and you now need to go and look at the stem and use the stem. So the same thing happens. When you get to the stem, read your questions, read your leading questions, go to the stem, But here they're asking you that of the options available, you can use once, you can use some of them more than once, or you can use some of them not at all. And with this one, pattern recognition, as always in this exam, as speed matters. So here is an example. So for the patient described, select the most likely diagnosis from the list of options. And here they've given you A to L. That's your option right there. That's your stem, sorry, your leading question. And now your stems come in. So you then get A. This is still in one, though. It's not two in one. It's still in one segment of the question. So A, 28-year-old footballer twisted his right foot inwards while landing, immediate lateral ankle pain and rapid swelling. He has, sorry, I didn't put that correctly. He has immediate lateral ankle pain and rapid swelling. He can take a few steps but hates bearing weight. On examination, there is focal tenderness just anterior to the lateral malleolus and pain on anterior drawer test. No medial tenderness. That's it for the diagnosis. You will then need to go back to your options and say, okay, of all they've described, which one picks the best one? And then you pick your diagnosis there. Now, the question is not over. Your part two of this extended EMQ, of the extended matching, is now the next lady. 65-year-old woman slips on a wet tile and fell. She has severe ankle pain, visible deformity around the ankle, marked swelling. She cannot bear weight, and there is tenderness at both medial and lateral malleoli. Select your best diagnosis. Again, you will come back to the options, and then you pick your what do you call it? Your best answer and your diagnosis right there. So this is what they mean by the extended matching questions. Unlike the multiple one MBA where you pick two, each of these one can be 1 mark. I don't know, but it can be 1 mark. So this is why we say that the number of questions you get is not linear because you just don't know which one has more than 1 mark. So that's the estimate. But all of this is so in AMQ you have part A, part B. It can be four questions under AMQ, and you need to keep going back to this to pick your diagnosis. And what this is trying to say is, assuming you were in musculoskeletal clinic and all the cases you are going to see are musculoskeletal pain, there is a special clinic in my area, ankle injury clinic. For anybody who has ankle injury, they all go to that clinic. It's faster than sending them to emergency department. So if I was sitting in ankle injury clinic and everybody's coming with ankle pain, ankle injury, am I able to make the right diagnosis? So my first patient has come in, my second patient has come in. They're all ankle pain, but what's the different diagnosis? That's what it's testing. So it can be cervical cases that you've gone to gum clinic, they're all cervical cases coming in, and then they will bring you different women's health problems and asking you to pick from the different women problem. That's the extended matching clinic. If you were in a special clinic and everything is the same, are you able to make the right diagnosis from the list of options given there? So our next exam question format is table or algorithm format. Now, with this, they want you to pick several options from the list to complete the algorithm on the screen, filling the blank spaces. So the questions will indicate the structure of the question will indicate whether the order of question is important or not. So looking at the structure of the questions, you will be able to tell how do you order them, how do you place them in an algorithm. Let's take a look. This is on DMAT prescribing, or sorry, drug prescribing, drug monitoring. All of these drugs are not DMAT, but it's on drug monitoring. And you'll be given a table, like an algorithm, and ask you which of these drugs fit in here. So if you look at the options here, this can come in as type the drugs or drag and drop. You will not drag it into the squares, but it's an algorithm kind of thing. So bone marrow suppression, which of these drugs causes bone marrow suppression? It will be methotrexate in the first one. Which of these drugs causes retinopathy? Hydroxychloroquine will go in the second space. Appetite suppression and weight loss is caused by methylphenidate. This then goes here. And then gambling is known as a side effect of aripiprazole, an antipsychotic medication. So that's the table or algorithm, drag and drop. Now with this one, it might be that each of them have 1 mark or 0.5 marks, so that by the time you're done, you are getting 2 marks if you get all of it correct. Now, the pitfall or the problem with this is that if you get one wrong, because if you move hydroxychloroquine to gambling and aripiprazole to retinopathy, that means that either you're only getting 1 mark or they've set it that you must get everything. Otherwise, you don't get any marks at all. You just never know. This is where those weighting comes in. So this is the format for table, algorithm, or drag and drop, or it will ask you to type it in. So this is where your prescribing comes in and understanding drugs that are monitored in the NHS. There are some drugs you can't just prescribe and they go away. Sometimes the question comes with how often should you be monitoring these drugs? How often should you be doing bloods, bringing the patient in and weighing them? Because methylphenidate used for ADHD can lead to severe weight loss in children. Every 6 months, they need to be coming in to be weighed, ask their appetite, and do bloods. And when patients default, they don't come in, we don't prescribe repeat medications for them. So if you don't understand the principles of drug monitoring in the NHS, that can lead to severe harm. That is why MHRA warning is always warning us with methotrexate and other drugs. And that's why they are testing our knowledge in this exam. The next one is picture format questions. So they will give you a picture. Common ones are eye, skin, and ear. But you can also get an ECG. You can also get an audiogram, a hearing test, or you can also get a picture of a joint like Heberden's node, which you can see in osteoarthritis, or Osler's node in rheumatoid arthritis. I hope I'm getting that right. But yes, you can get a picture of somebody's hand and tell you what is the most likely diagnosis or what's the action that you're going to do. Are you doing bloods? Are you doing X-ray? Are you making a referral? Because rheumatoid arthritis, you need to do an urgent referral within 3 days to be seen by the rheumatologist for rheumatoid, if you are suspecting rheumatoid arthritis of the hands. Because if the hand is deformed, it can be life-changing. So it's an urgent referral. So they will give you the picture there and they will ask you what's your management, what's your diagnosis, or what's your management, or what are you prescribing, or what are you going to do. So again, same thing is read the questions, go to the STEM, and then look at your picture. So with this kind of ones, this is probably the only place I would say recall matters. If you have not seen a picture, you don't know it. So you will need to really, really look at a lot of pictures over and over and over again. It's like when we were doing histology and we kept on looking into microscope, the microscope, and we were frustrated with looking at those pictures because without looking at those pictures, you can't memorize that this is what lamina propria looks like, or the lining of the intestine look like. I was frustrated back then, but yes, that was the learning format for histology. And in picture format, that's the same thing. And in your SCA as well, you will also get some cases with pictures. If you've never seen a picture, you can't manage that. So here is an example. Anytime I see this picture, I always think of a planet. So again, our basic comes in, what is the most likely diagnosis? Select one option. The question can say, what is your next line of management? Or what is your initial management, or what is the diagnostic test to diagnose a condition? It can change. So what is your most likely diagnosis? Select one option. I then go back into the STEM. This is an ophthalmology, so this is the eye, not the ear. Of course, we should be able to know that, okay, these are some blood vessels and the optic discs of the eye where the blood vessels are coming out from. And I believe the macula foveae, if I remember very well. Now, trick question. I was doing a GP self-test with my supervisor, and one of the pictures came as a normal retina. And because I was memorizing back then, I just recalled and said, oh, it is this. My supervisor looked at me and said, are you sure? It was a normal retina. So they can bring normal findings to you. It's not a trap. It's to make sure that, oh, you are able to tell normal from abnormal findings. So yes, there are some questions with normal findings as well. But important to know. This is where you don't memorize, just, know your patterns. So the question says, a 62-year-old woman with a history of hypertension, again, age, risk factor, and hyperlipidemia, risk factor, presents to the surgery urgently. That means this is sudden. She's stressed. It's not something that's been going on gradually for a long time. With monocular visual loss, that means one eye. Whether it's left or right is not important. That's a distractor. But with monocular visual loss in one eye, they're asking you to interpret. Noted on waking up this morning. So she woke up with it. There is no time. What's your most likely diagnosis? And the answer is retinal vein occlusion. Important to know the difference between retinal vein occlusion that gives you the fire flame appearance and the difference between retinal artery occlusion, where the entire field is pale, because with artery there will be no blood supply. The field will be pale, like yellow creamy color, compared to vein, where the vein have ruptured and there is blood all over. I had to form my patterns in recognizing these things because I'm the kind of person that I can't cram, I can't memorize. I need to go to the foundation to say, why is this different from the artery occlusion? And I had to know, okay, in artery occlusion, artery is occluded, there's no blood supply, it's pale. But in vein occlusion, the vein is blocked, it ruptures, and it gives you the fire flame hemorrhage appearance. So there is another question with this same picture that says, what is this appearance called? And you will see the fire flame appearance, and then you now need to do your next appropriate management. So again, same things can come, but questions can change. I don't memorize, I don't know how. So I always have to go back to the foundation of my learning. And that's what makes me, I think it's my style that makes me better today. So here's another picture of picture format, for example. This is a pregnant woman. So again, the intro says rashes in pregnancy. The first thing you do is read your STEM. Which is the most appropriate initial treatment? Select one option only. So it's single base answer, select one option, but picture format. So Again, then I go to my STEM. 27-year-old prima gravida, that's it. The age is telling you pattern recognition. Polymorphic eruption of pregnancy. The full name is purpuric urticaria papules and plagues of pregnancy. PUPPP. It's a long one, so I always have to go back and check it. I've only seen this case once, and I saw it as a GP in urgent care. And I was like, oh my word. But I had to study it in the AKT. So you have to go into your STEM, 27-year-old, primi gravida, pattern recognition. Intensely itchy rash. That's the clue right there. Intensely itchy rash, lower abdomen. Most times it's always only in the bottom here. It started with a striae. So people who have stretch marks in pregnancy and they start itching the stretch marks, it then worsens and leads to this. So you see that they did not give you the diagnosis. They expect you that even if you don't know the long name, you easily recognize this and you take action immediately. The lady I saw, she was unwell because hers had become infected with cellulitis. So I sent her to the hospital. Hers was extensive. But if it was mild or something I could manage, the answer would have been steroid cream as initial. You see the clue right here? This is why I highlighted initial as initial management. Because what if it says, what is your most appropriate diagnostic treatment or diagnostic management? That changes everything because it may come and say she has tried steroid cream and hasn't worked. What is your next line of management? So that means if she's tried steroids and not work, you're not going to give her steroids again. What would be your next step? Is what you're not asking you for. So this is where you say, okay, you are looking at the picture, you're recognizing it, you're going into the STEM. What are you looking for? Your most appropriate initial treatment. Your STEM now has not given you information. She's not hemodynamically unstable. She's not unwell. She just has the rash and it's very itchy. So don't assume, oh, what if she's unwell? What if they didn't say? Don't overanalyze. What is there is all you need to make that initial management. So that's why they say don't overanalyze your questions. Don't start saying, oh, it didn't say whether she's fine or not fine. Is he infected or not infected? You don't need all of that. Just focus on what you have already been given. So that's the picture format there. And you can have it as ECG, you can have it as hearing test, you can have it in so many ways, but it's picture. Our next format is data interpretation. And with this, this is where your statistics come in. They're asking you to interpret a statistical report. They're asking you to look at either chronic data. So they may bring a statistics of, this is the statistics of prostate cancer or lung cancer in a particular region, which region has more, or which gender has more of this versus more of that. They're asking you to interpret. And this is because we are going to do research, we're going to do QIA. These things are important for us in GP practice, so that we are having the right skills. So also they want us to be able to know which graphs. So this is a what kind of graph is this? So this is an example. What's the name of the following statistical chart? They want us to identify the type of graph. So the simple bar chart, yes, but we need to know whisker plot, we need to know funnel plot, we need to know and identify the type of graph. And sometimes they will bring you lab results. Especially, I recall learning about T-score in osteoporosis. That's why I put it there. They bring you lab results and the graph of the lab results and ask you to interpret it. Does this patient have osteoporosis or osteopenia? Or they will bring you an audiogram, which is a hearing test, and show you the lab results of the audiogram and ask you to interpret it, including ECG as well. So that's where data interpretation or pictures also come in. So here is an example of a national statistics, and something like this can also come. They will then ask you, based on gender, so looking at the age for age 50 to 40, which of them do not attend hospital the most? So this is, look at it, then your outpatient who did not attend GP surgery in the area in 2019 to 2020. Look at your values. We've done some of these things in exams. Look at your values. This is age, and this is per thousand. See it? It puts in 100, but it says in thousands. So it might then tell you that for age 50 to 40, how many men, men is blue. How many men did not attend GP surgery? So that would be my blue one here. Let's take it down. I'm going to about, let's say, 220. Now, your answer option can come as 220, 220 men, 220,000, 2,200. You see, but if you just come down, see, some of them are distractors. That's what I'm trying to get at. If you just come and say, oh, straight down, 220, but you did not look that this is thousands. You have picked 220, but you're meant to be in thousands. So some things are very easy, but you just need to know the trick to them. That, oh, wait, am I putting in the right metrics for these 220 men? Am I putting in the right metrics for them? So that's an example of graph interpretation. That they're not just asking you to know what age range, know whether it's male or female, be able to read it down. But this is where most of us make a mistake here. That's a common pitfall. And then the free text question format. That's the next one we're going to talk about, the free text question format, where you'll be given a question, but they will ask you to type in your questions. I recall they said this is when many IMGs get trapped because they want, it's just the way like the last one where it's 220 versus 220,000. We always just type in without reading, is this a percent? Is this in thousands? Do you need to break down the maternal mortality from 50,000 to whatever it is figure they're asking for? So important to look at what that final request. So an example may say, oh, calculate the percent of doctors who attended elite exams lecture on a Saturday morning. And you calculated that it was 0.7 out of 10. So 7 out of 10 doctors attended, and that gives you 0.7. But my final thing was calculate and write in percent. But you just go and write 0.7. Meanwhile, they were asking you in percent. So sometimes the question might say you can write it as number or percent, or you can write it as a fraction. But you need to know that if it's asking you to write it in a particular format, please don't mix that. That's something that the little thing there that we can easily miss. You got the right answer, but you didn't follow the right information. So that's the free text one. But sometimes, like in the drug one, they'll tell you to type the answer, type the drug, type the answer to the question, and then you put it there. The next exam format is ranking order. They will present you a list of drugs and ask you to rank them in ascending or descending order. And that's the trip, the pitfall there for IMGs. And for somebody like myself, I skim a lot. I will read the stem and say, okay, rank this, and then I'm gone. I'm going to start ranking. But did they ask me for ascending or descending? I know that I constantly skim, so I'm always mindful of that. So always know. So examples of this is steroids. So you need to know your steroid strength, your pain medication or opioids. You need to know your strength of them. And this is an example. So again, you come and read your stem. Which of the following represents the order of preparation from least to most? So now they're asking you to rank it in ascending order. Yeah, in ascending order from least to most of the potent steroids. And they've given you a list. So you now need to look, okay, from the list, which is the list here, this is the list. This is the next one. So you are ranking the strength of your steroids. This is the next one. Then you're number 4, and then you're number 1. So if you don't know your strength of steroids, you can pick any combination. Or if you are doing it from most to least, you are not going to do it in reverse by picking 1, 4, 2, 1. But we don't have that option here. But this is how ranking orders come in your questions. So we've finished the end of explaining the format. And here are just quick exam things to do before, as you start to prepare. Start early. Your ST1, 2, so you're 6 months into your GP training, the best recommendation is to start now. And if you are aiming to write this by the end of your ST21, that gives you 12 months period to write. Because again, we advise that at the beginning of your ST21, so 1 year from now, you should have done your AKT and start preparing for your SCA, actively preparing, so that you are doing your SCA in that early part of your ST3 and not be under pressure. Widen your resource base. I've given you a list of study materials, including the videos and audios that I used, different types of learning formats. So please widen your resource base. Don't just focus on one exam questions. GP self-test alone is not enough. Focus and use loads of resource base. Avoid cramming. I've mentioned this several times. The curriculum is a lot. You can't memorize the entire curriculum. But if you understand how to use pattern recognition, you'll be working smarter and studying better. If you cram, you will increase your anxiety because under pressure, you forget the things that you have memorized. But when you have a habit, you fall into that habit and you are able to perform with that habit, even when you're under pressure, because that habit is natural to you. And that also applies for the SCA. If you are cramming, you're only building short-term knowledge. You just cram, memorize it for the exam. After you slept, you forget everything. Meanwhile, the knowledge you are learning here, you are going to need it in your SCA. So your study here, always remember that you are also studying for your SCA, because if you don't know your pattern and a patient you are consulting, a patient is telling you their condition, you will not know. Even in GP practice, you won't be able to correctly diagnose and treat that patient. We know that our GP journey is different for each of us. Some of us have families, some of us have other things in our life that matters. So we are all on a different phase. Be realistic with yourself when you are setting your exam time. Find people who are writing exam in the same month as you. If you are writing exam in March and you are studying with somebody who is writing exam in November, that person still has time to sleep and rest. Meanwhile, you are anxious and you want to move faster because your exam is in 2 months' time. Meanwhile, the other person is not under pressure like you. So find a group and people who you're accountable to, but they're writing exam in the same period as you. You are all aiming for that final goal at the same time. Don't follow the crowd. Oh, my friend is writing in March, so if I don't write, I feel like I'm behind. Your friend is single, does not have 3 children, does not have other things that they need to worry about. They just go home and they're dead studying. So they don't have that responsibility that you do. Be realistic with yourself when you are forming your group. When I formed my group, we're all mothers, we're all GP trainees, we're all Nigerians. So we give ourselves the accountability, the expectations that okay, we can wake up in the morning when the kids are still asleep. But if my child wakes up and is crying and I need to turn off my camera or my mic, don't be upset because kids are here. So we were all moms and we understood ourselves. But imagine if I was in a group with people who were not moms and I'm not coming to practice because my kids is unwell or something. So people will kick you out of the group. Yeah, people are that um, strict in their groups. So please make sure that you are setting expectations in your group before you start, and you are practicing with people who understand your situation, or you're practicing towards the same month, and you are kind and gentle to each other. Have a positive mindset. The exam is not meant to trap us as IMGs. I know a lot of people say the exam is meant to trap us. They deliberately make us fail. I practice transformation leadership. I practice thought leadership, and I take time to look at systems. I believe in building systems to help ING. And in studying systems, in studying this differential attainment, where IMGs fail the exam, 50% of us fail these exams in RCGP. I found that it is not because RCGP is trying to trap us. Nobody is intentionally making us fail. It's because as IMGs, we do not have platforms that, number one, tells us the truth. Number two, create resources that is tailored for us. Because sometimes this platform just copy and paste, they move on, they just want to collect their money. But none of them really take the time to give that personal mentorship to IMGs. It's time consuming, I understand. But if you are struggling with certain things, you have learning differences which I'll talk about, please don't hesitate to find the right support for you and have a positive mindset. It's not possible to have 100%. Nobody aims for perfection. Even me as a GP, while I was doing some of the questions to prepare for this lecture, I was still failing some. Nobody gets 100%. When you start practicing and you start timing yourself and doing mocks, you should aim for consistent 80 to 90% pass in your mock exams with GP self-test. Because if you are constantly doing that and getting 80 to 90% pass in your mocks, there is a higher chance that in the exam you are going to get a high chance of passing in the exam. That's the advice they give. But if you are getting 70% pass, which is acceptable in your mock, 70%, that's what you're aiming for in the exam, 70% pass. Because it might go up to 71, 75. I've never seen up to 76. 71 to 73 is the average. So you're aiming for that average pass to be above it. But in your mocks, if you are aiming for 70% pass, in the exam, you will fall below the expected average. And that's the advice I learned from my VTS as well. Before your exams, once you've paid, identify the VU session, the VU PSC session near you. Check the postcode, drive to the place, or before your exam day, look around. If you're driving to the exam, is there a parking space? Nowhere to park. You don't need all that stress before your exams. Nowhere to park. Is there a parking meter? Do you need to bring coins to put in the parking meter for your exam, or do they accept card? My advice is go with both of them. And some places now is digitized. Have the app on your phone so that if the parking meter is not working on that day, you can use your app and pay. If you don't plan on that day, you'll be stressed. And sometimes we see stories of, oh, I was driving and I was so stressed and I got into an accident before my exams, or the morning before the exams, or I parked in the wrong place and they locked my car while I was in the exam. We've heard all these stories. Failing to plan means you might be planning to fail. If you go there and the place is always overfilled with cars, it'll be difficult to park, and you don't want that stress in the morning. Can you book a taxi that will come early so that you arrive at the center early and you don't have to deal with all that stress? You plan. So that's all the things that they tell us that we should do. Rather than in the morning you're not looking for the location, you are 15 to 30 minutes late or arriving just as you're about to start simply because you could not find the location. So please plan ahead. For us as IMGs, many of us coming to this country, we either don't believe or we have not heard about learning difficulties. Back in our home country, if you're struggling to pass an exam, they will either say it's not for you, they will say that you're not smart enough. But many times we don't have conversations that people have things like dyslexia, ADHD, dyscalculia. If you're hearing these things for the first time, please go back and update your clinical knowledge. Dyscalculia is difficulty in solving maths question. So somebody with dyscalculia would struggle to calculate maths with their bare mind. They would always need a calculator. And your what do you call it, your computer at home or even in the exam, there is a calculator there for you. So if you know you have dyscalculia, get that calculator set to one side so that once you are getting on your screen, get the calculator opened up on your screen. So that once you are having a question with calculation, you are using your calculator. Nobody's expecting you to be a superman or a superwoman in the UK. Know your learning differences. If you know you have one, apply for exam adjustment early. Now, somebody has told me I didn't want to feel labeled. And yet this person was struggling at work. They were being marked down and they refused to disclose to supervisors that they had learning difficulties. I prefer to call it learning differences because it's all about knowing your learning pattern and finding what works for you. Somebody with dyslexia, if you identify that you are easy, you always skim, you are always mixing words, because some people, dyslexia comes in different form. It's not only about the person cannot read. That's the severe form. Mild forms is, if I want to read exam adjustment, I may read it as exam education, but meanwhile my mind is thinking adjustment, but I'm thinking of education. Or if I want to say, I want to prescribe amoxicillin, but I might switch words and say, amitriptyline. I'm going to prescribe amitriptyline. I'm saying, oh, I'm so sorry about that. I'm going to prescribe you amoxicillin, which is an antibiotic. So in that kind of situation, I learned the tactics of managing different exam or learning differences. Because with somebody with dyslexia and you are always switching words, you need to know when to slow down your words and allow your brain to catch up, because some people, some of them are very high IQ, so the brain is working in overdrive, smarter and working faster than the mouth. So you have to learn how to manage your learning differences. And if your learning differences is affecting your performance in exam or in life, please apply, get the assessment, contact me so that I can tell you how to get your assessment. Have it documented, because it will save you in GP training. It will also save you in the workplace, where the GP is expecting you to work in 10 minutes, but your learning differences means that you need to slow down to type and correct the words you switch before you save your records. That kind of person needs 15 minutes work time in real life. But if you are saying, oh, I don't want them to think bad about me, God forbid, it's not my portion, it's not my this, and you are struggling in real life and you're making real life mistakes, then you are sabotaging yourself. If you are having learning differences, please reach out to me so that I can signpost you. Or if you suspect, for example, if you've written PLAB 3, 4 times and you know you gave it your best, you have to think about it. Do I need to be checking? And what you need to do is just do the screening questions, screen for it. If it's not there, you know it's not there. Maybe you didn't have the right resources. But if it's there, then you need to go further and get that formal assessment and make sure that you are having the right exam and learning support and workplace adjustments so that you don't struggle in real life. In real life, you see doctors who have physical disabilities, and lens differences is not, we don't wear it like clothes, it doesn't show, but there is real impact in this thing. And it's affecting us as IMGs, because many times we come in that we are afraid of disclosing it, or our cultural or faith belief, and we say it's not our portion, and yet we are actually failing the exams. On the exam day, the day before, please make sure that you get your IDs printed, you have all things ready, wear comfortable clothes. Trust me, you're going to be sitting down for hours. Wear comfortable clothes. Make sure that if you're writing in the summer, you're not wearing thick winter clothes. If you're writing in winter, you're not wearing light summer clothes. Or for me, what I did was, I wasn't sure how my center was. So I wore a shirt and I made sure I carried the cardigan to take on or take off, just to make sure that I'm not struggling with cold, because I struggle with cold. So I had to go prepared. Arrive early, settle down, have a positive mindset in your exams. Think positive always. If you are the kind that carries your study materials to the exam hall, please, I would advise you to leave it at home on the day of your exam. You are only adding to your stress. If you've not studied something for 6 months or 12 months before your exam, you will not be able to study it 2 minutes before the exam. So please don't stress yourself, because the exam is really stressful. If you are struggling with exam anxiety, please make sure you are seeking help. There are so many help available. There is practitioner help where you can receive counseling and practical advice on how to deal with exam anxiety. I was one of those people who struggled with really bad exam anxiety, and I got professional help. You will not believe I am the one who turns on my camera today and talk about things. But that years ago in the exam, my hands will be shaking when I'm taking exams. It doesn't mean that I'm not smart. It's just because under pressure, I don't perform very well. So I needed that adjustment for exam anxiety. I've also been, I've also worked with colleagues who go as far as speaking to their GP, getting propranolol for the exam, getting SSRIs, or actually just having somebody to sit with and talk to, and have loads of positive affirmations so that and build their confidence to pass the exams. One thing doesn't work for everybody, so please check yourself, know what is affecting you, and reach out for help early, because getting exam adjustment and applying for assessment is going to take time. And if you're not assessing yourself early and you're already in your ST2 before you are going to look for support and help, that means that you'll be entering ST3 before you finish or pass your AKT. Always think about time management. You have 57 seconds to write, to pass the and to do a question. So if you read a question, the first thing that comes to your mind, that's called first pass, because there is a reason that it came to your mind. Immediately you identify the pattern and that it came to your mind. But if you start over analyzing it and saying, oh, what is this and what is that, and you now go back and start changing, there is a high chance that you are changing your right questions to wrong questions. So know when to, how to manage your time. Flag your question. So if you are seeing a question is difficult, or a topic you don't know, or the question is very long and will take you time, flag it and move on quickly. In the very last part before you submit, there'll be a review page. So every question you have not answered will now show, and you can now go back and click on them. and answer them specifically based on your time. So this is also a smart way to manage your time and make sure that you're covering as many questions as possible. There is no negative marking. So do not leave money on the table. That's what I say. If there are questions there and you don't answer them, you are leaving money on the table. I'm hoping that phrase helps you understand. You are leaving your marks on the table. So as much as you can, answer your questions. And there is something that I heard. They said, oh, if you see a question and you have absolutely no idea, like absolutely no idea how to answer the questions, and you are going to guess, pick B or D. And that's what I heard from I won't say this, I won't say where I heard it from, but that's what I heard. And yeah, there were one or two questions that I came across that I had absolutely no idea. And if I were to pick B or D, and I picked one because I have no idea and I was guessing, and 50% chance is that it's B or D if you are guessing. We are hoping you don't guess in your exams, but please, study wide and broad and don't leave any questions unanswered simply because you don't know it. Answer, pick something. It increases your chance of getting it. Answer everything. Manage your energy. That's something I do. And for me, on the day, you know your pattern of eating. Some people will say, if I don't eat heavy meal in the morning, I'll be hungry and I can't focus. If that's you, please make your eba and eat in the morning. For somebody like me, I don't eat breakfast, but I need my 2 cup of tea. Otherwise, I'll be grumpy. So that means that by the time I'm writing exam and it's already 10, 11 o'clock, I'm already hungry and my stomach is growling. So to manage that in the exam, I went with my water. I had a fruit, and for me, my fruit of choice is banana. Banana releases slow energy. I always talk about banana a lot. It releases slow energy and keeps your strength up because you're going to sit down for a long time. If you're going to go with something, nutritious to drink, I think there is a restriction on what you can bring. I think it's just water, but find a way to manage your energy in the exams and know your strengths and the things that bring you down when you are working for hours. There is no break. If you need to go to toilet break, your time will continue. Your time will not be paused. So use the loo before you start, and if you need to go use the loo afterwards, please make sure that you are fast because your time will not stop when you go to the loo. Common pitfalls. If you are always skimming the questions and not reading, the pattern, the way we've learned it today, reading the stem, then going back to it, you're just skimming, I memorized it, I know this is going to be this, and you're just clicking and going. They will change the questions, they change things, and new questions that keep coming. So it may be the same topic, Wilms tumor, but now they've changed something in it, where it might be the urine test is now abnormal, and that's not Wilms anymore, that's another kind of tumor, which is polycystic. So don't just skim, don't just say, oh, I've seen it, I know the answer will be this. You are memorizing and you fail things like that. If you're overanalyzing your questions, you will then end up changing your right answers to wrong ones. Use the first pass where you read it, that first thing that came to your mind, pattern recognition. Make cross check and just make sure, but don't overanalyze. What if they meant this or meant B? That's not what is here. The questions are not meant to trap you. Right now, start building your skills on pattern recognition. You need it in real life clinic, you need it in the SC exam. Without this skill of being able to identify conditions quickly by saying, oh, she just described a patient with chest pain, diaphoresis, hemodynamically unstable. That's an ambulance. That's pattern recognition right there. That's something that I didn't know until the very last stages of my AKT. And my supervisor called me and said, you need to go to this Ian Lauter's lectures and listen to what he says about pattern recognition. And that's why I loved his lectures back then. The exam is not trying to test us as medical students or SHOs. We are meant to be operating at the level of, or studying towards the level of an aspiring new GP. So your questions are not going to come like medical students. Don't interpret, make sure that you're reading the questions well. Don't jump to conclusion. Especially if you're memorizing questions, you will misinterpret or think, or seen it, and then you're clicking the wrong thing. We've talked about the mistakes with ranking, where you might instead of to rank from least to ascending to descending, or you are ranking in the wrong way. So be mindful of the common mistakes in each of them. If you have exam anxiety, please learn to control that. Find help early. If you have learning differences, like we've talked about, it's nothing to be ashamed of. It's actually brave and acceptable in the UK for you to talk about it and go get help than for you to hide it and compromise your career, or more importantly, compromise patient safety. If you have a learning difference or a difficulty and it affects patient safety, for the fact that you hid it intentionally, that can lead to probity in GMC. And I've had situations where, sorry, no situation, it's not somebody I work with. I actually saw it online, so I'd like actually give a story. It's online there. I'm not giving anybody's personal history here. An online story of a doctor who had a mental health condition, a psychiatric condition, and was on medication from his home country, failed to disclose it in the UK, failed to disclose it to the GP, was requesting medication from home country, and then had a mental health breakdown, and that had to be referred to GMC for probity. So many wrong ways of managing that. So these are examples of INGs who don't want to disclose this. Meanwhile, they could have got exam adjustment, they could have got the right support right here in the UK. But that cultural fear of being stigmatized has led to losing medical license or something because of probity and compromising patient safety. It's an online story on Facebook, so anybody can check it out there. Know how to manage your time. If you are feeling stuck in your AKT preparation and you're not sure what to do, this is why I'm here. This is why you are a member of Elite Exam. Message me and let me know so that we can talk about it and find things that helps. We've talked about no unanswered question. Don't leave your money on the table. Don't leave your marks on the table. Make sure that you're answering everything. And then some doctors would focus a lot on clinical problems and leave the statistics and practice questions till 1 month before. But those topics may only be 10% of your exam, but there are a lot of topics in there. And if you neglect those things, you will then struggle, and don't get those marks to boost you in the exams. So I hope this has helped us learn for the exams. I've also given a timeline that, okay, you're starting to learn now, but in your last 8 weeks, what should your final count be? In that last 8 weeks, start doing time mocks. Start identifying areas or clinical specialties you've not done. If you know you've not done ear, if you know you've not done skin, start focusing a lot on them. I'm hoping you will have a schedule and do them, but you need to start assessing yourself to say, oh, I'm using mocks to find out which domains, which clinical specialties do I fail the most. So when you do a mock and GP self-test says you failed more questions in psychiatry, you need to do a deep dive in that clinical topic. Make sure that you are covering every areas, organization questions, prescribing, and then your last 2 weeks, every day, sit or no, not every day. Apologies, because I was corrected that was stressing me out in the exam. I was told to do it 2 to 3 times a week. In that last 2 weeks, close your door, sit at your table, put your timer on, and time yourself to have full marks like you are doing the exam. And then that final week, you are going to start your positive affirmation, light revisions, making sure you're having good sleep. Time yourself that you're not sleeping less, you're sleeping more that week because you need to manage the pressure of doing